trying to suppress me. Basically, they're trying to suppress me. They're trying to stop me from doing live videos, but I will not be repressed by the powers that be. I've still got a lot of support in Facebook and the YouTube, in the towers of power in YouTube and Facebook. So I'm still doing a live Q&A on those platforms, and I will continue to strive to be a voice for reason and for plastic surgery questions, but not in a live fashion on Instagram. God, goodness knows why. But they're saying I'm not. I can't do it on my account. But anyway, I'm on YouTube and Facebook at the Staiano Clinic if you want your questions answered. I'm doing it now. I'm actually live as we speak, so I better go. That, yes, right. Instagram are still doing, right. You know, they're still done. Now something's going off. It's all kicking off here. So why don't I just stop that? Video can't be posted. Right. Anyway, Q&A is what this is about. Let's just not forget why we're all here. All of you, why you are here. And thank you all for being here, by the way. Each and every last one of you. It really is touching to see so many people here tonight who come along to support me in my Q&A endeavors. So really, you, the people, are the real heroes, not me. Oh no, it's not about me, it's about you, the audience. And you know, it really is it's touching to see so many people here today. So thank you all for coming. I know you've all busy and you've taken time out of your busy schedule to join me on this live Q&A. So if you've got a question, then please ask it. But fortunately, I've got some questions in the bag, so I will go through those at my leisure, and I will feel free to be interrupted by one of the crowd. If anyone wants to raise a hand, then please do, and we can always go off on a tangent. I'm always open to tangential discussion, but for now it seems it's going to be a linear progress, which is absolutely fine. So why don't I just answer this question here? Do we offer umbilicoplasty? I don't know if this person is asking for something specific in terms of umbilicoplasty. I mean, plasty basically means changing the shape of, and umbilico is umbilicus, you know, belly button. So kind of changing the shape of the belly button covers a wide range of procedures there. So it can range from umbilical reconstruction. So for people who are born without a belly button, people who are born with abdominal wall defects and don't have a belly button, so that would be an umbilicoplasty, creating a new belly button. It's usually used for part of a tummy tuck, where you do an umbilicoplasty, where you resite the umbilicus. You keep the stalk and you resite it, and there's techniques for doing that to get a natural looking umbilicus. But it might be someone with an abnormal, like an outie, for instance, or an abnormally shaped belly button, or a problem with the belly button after a piercing. So it can cover a wide range of things, but in broad terms, yes, we do change shapes of belly buttons, and we do things to belly buttons, and you will be surprised. It is quite a thing, the structure of the belly button, and there are many papers written about it, one of which is mine. Well, actually, Mr. Naranjan mainly, but me and Mr. Naranjan. I wrote it, he came up with the idea, but anyway, both authors on it. And when you write a paper on something like that, on how, and my paper was about how you reinsert the umbilicus at the tummy tuck, a technique for doing that. But when you write a paper like that, you realize how many papers there are out there. There's a lot of people who've kind of researched what the ideal shape of the umbilicus is, and how we go about making it look aesthetically pleasing. So yeah, I guess if you're going to have anyone do things to your belly button, plastic surgeon is going to be the one who is sort of who does do umbilicoplasty or umbilical reshaping or umbilical reconstruction, whatever you want to call it. But short answer, yes, we do. Yeah, we do. We do umbilicoplasty. So how long does it take for a scar to fade after having a mole, cyst, or lipoma removed? Sometimes we put these clippets a word, isn't it? It's clips of this on Instagram, just with the not on Instagram, on YouTube, just with the clip and TikTok, and I did one a while ago. Say, I've done a couple actually. How long do dissolving sutures take to dissolve, and what's the cost of mole removal? Both of them were like this. Someone's asked that question, and then I have to answer it on the live Q&A, and then we post it on YouTube as a video saying cost of mole removal, or how long do dissolvable sutures take, or like this one, how long does it take for a scar to fade? And then everyone berates me because I don't give an answer. You know, they're like, well, he hasn't told us how long it takes to dissolve the suture. He hasn't told us what the cost of mole removal is. He hasn't told us what this is. And I'm like, because the fact of the matter is, most of these things, the answer is, it depends, which is very unsatisfactory, I do know. But it does depend. It depends on the site of the body where it is. So around your ankle heals very slowly and has got a poor blood supply. Your face heals very well and will heal more quickly, and the scar will fade more quickly. It depends on your age. You heal more quickly as a young person than you do as an old person, but the scar fades better as an old person than a young person. It depends on how much tension's on the wound, so how big it is. So moles are skin lesions, so we take out skin. Cysts and lipomas are subcutaneous lesions, so we don't take out much skin. So hopefully a cyst or lipoma, the closure wouldn't be too tight. But a mole, you might have tight closure, which might make the scar a bit more red for a bit longer. It depends on how the healing goes. If you have delayed healing for whatever reason, bit of infection, it might take longer. It depends on your skin type. If you have a very pale skin, you might form scars that are a bit more red and take a bit longer to fade. Some people do make worse scars than other people. There are people who do scar well and people who don't have good scars. So there's a variety of factors which will come into it. But what I normally say as a kind of ballpark answer for these sorts of questions is that the skin's healed in a week, and that doesn't matter if you're having a mole removed or having a tummy tuck or you're having a facelift or you're having a, you know, whatever operation you're having. Basically, the hope is that the skin's healed in a week, pretty much. I mean, obviously you can get problems with delayed wound healing, but the idea is that the skin should be healed in a week, but it's not very strong, so you leave it a few months before you do anything to it. And often, if you look at it a week, it actually doesn't look bad, and you look at it at 6 weeks and it looks more red. So they often go more red before they go less red. So if you look at it a week, you think, oh, that's a good scar, happy with that. And at 6 weeks, oh my god, it's all red and hard, and that, you know, because as the scar gets stronger, it gets more red and a bit more lumpy, and then it fades. So I normally say 3 months is the sort of time scale I give. For 3 months, when things start to fade, that's when things start getting better. We talk about scar management, massaging the scar and what have you. We'll talk about that in the clinic, but basically 3 months is when it starts to fade, and then it's 6, 12, 18 months for it to properly fade. So again, broadly speaking, a year is kind of like the time that most people would say is when you're fully faded, but it's sometimes 18 months, you know, sometimes it's still a bit red at a year, so you can't 100% say that about everybody, but broadly speaking, a year is kind of what you're looking at in terms of the fading, and what have you. And so yeah, 3 months for it to start to fade, 12 months for it to properly fade is the short answer. So hopefully, if this does go onto YouTube or TikTok or something like that, it won't require, you know, won't have loads of people berating me. Having said that, I think it helps having comments. So bit of a win-win, really. I mean, but that no, because that would be clickbait, wouldn't it? People say, oh, it's clickbait. I'm like, it's not clickbait. Someone's asked me a question, what's the, you know, how long does a dissolvable suture take? And I'm attempting to answer it. There's loads of dissolvable sutures, so I can't give an answer. It depends on the type, you know. So it's not that. It's just me trying to answer these questions. I think they think I've posted a video of that and I've like instigated this myself, you know, which is like not, yeah. In my defense. How do we offer encapsulated seroma removal surgery? Now, instantly, I think I can say this is probably not our patient. I do remember I did have one with a patient who had one behind her knee, surprisingly enough, an encapsulated seroma, which I had to remove. But it's a very rare problem, an encapsulated seroma. And I'm thinking, just by the nature of the question, I'm thinking it's probably a tummy tuck, because that's kind of like the normal area where I would, where you would get this sort of thing. And so the answer to the question is yes, we do offer encapsulated seroma removal, but the preface to that is we would not offer it if it's someone else's. We don't treat other people's patients. So if you've had your surgery somewhere else, the advice is always to go to that other person and to have treatment with them. So we wouldn't really take on a person who has a post-op complication like that, because it would be classed as a post-op complication, and there would be a vested interest for your surgeon to do it, and often you would do it maybe with no cost or certainly reduced fees if it was your case. But if you went to someone else, they'd probably charge you full whack. So we wouldn't do it if you had surgery with someone else. But if you've had surgery with us and you've got an encapsulated seroma, absolutely, yes, we would do it. But as I say, it's an extremely rare problem that you hardly ever see, or I hardly ever see anyway. Certainly a tummy tuck, I don't think I've ever had one in a tummy tuck, but it's out there in the world. So I'm not saying it's like a kind of like really rare, but it's not like a common thing. So yeah, I've had a few flat moles that I've lasered 2 times. 2 times I've lasered it 2 times, but I barely see any difference. The doctor told me that if laser doesn't work for my flat moles, nothing will. But it is possible to get rid of flat moles with excision, right? Yes, right. I'm not sure I would necessarily 100% agree with that doctor. Actually, probably 0% agree with that doctor, saying that if lasers doesn't work, nothing will. That's not true. The thing about doing things like laser for moles is that you're using thermal energy to burn the mole, basically. And if you do too much, you're going to get too much scarring. If you do too little, you get a residual mole. So that's the problem. If you don't do enough, you can obviously get less scarring because you're damaging less skin, but you will then, when the skin heals, the pigment cells will still be there. You need to destroy all the pigment cells somehow. So I would, so a flat mole can always be removed by excision. And going back to the cost of mole removal question, it depends on the size and the location, because you can get very big moles, but most moles are kind of small moles. Let's be honest with ourselves. Most moles are small moles. But any size mole, we can certainly talk about removal. If a very big mole, you might be saying the risks outweigh the benefits, but that's kind of up to the patient, really. But generally speaking, any flat mole can be removed by excision, and I would say excision is the best way to remove it. I would say that. I do say that. And I'm not just saying that because we do it, because I don't mind who does it. You can have anyone do it. I'm saying that because I think it is the best way to remove them. You can be very, it depends on the type of mole. Sometimes we do shave excisions and stuff like that. But a flat one, you can't really do a shave excision. A flat mole, a flat pigmented lesion, probably is best to be sent for histology, number one. So we can be sure that it's nothing sinister. And number two, you can be absolutely sure that you're removing it. There's no kind of question that it might come back or anything like that. It's a guaranteed, really, result. So I think, and you can be clear about how much skin you're removing. You do a very minimal margin, usually for a benign mole, and so you get the minimum scarring. Whatever you do, there's going to be some scarring. And I think anyone who says there's no scarring is like, well, the scarring might be so good you can't see it, but you can't really say there's no scarring. There is a kind of, especially if it's a full thickness injury, whether that be with acid or laser or a knife or a spoon, scraping or whatever. If there's a full thickness injury, there's going to be a scar. Lynn's in. Look, there is life. Lynn, what you got? Can you have loose skin if you lose weight after tummy tuck? Yes. Hold on a minute. Can you have loose skin if you lose weight after tummy tuck? Yes, you can, Lynn. And that is why ideally, and I know it's not an ideal world, but ideally, if you're going to have a tummy tuck, you would not lose weight afterwards. So I always say to people, you don't want to have weight fluctuations either way for a tummy tuck. So sometimes people say, oh, I've got, I know I'm overweight, but I find it very hard to lose the weight because of this abdominal apron. And I'm like, you're better off not having a tummy tuck. So I want to have the tummy tuck because then I can exercise better and all that sort of stuff. And I completely understand that. But if you have a tummy tuck and then you exercise and then you lose weight, you're going to have redundant skin. You're going to get loose skin because we make it as tight as we possibly can when we do a tummy tuck. But if you then lost weight after the tummy tuck, that would cause the loose, to have more loose skin, which we could have removed if you'd lost the weight first. So you're 100% better to lose the weight prior to your tummy tuck because you can get an annoying, bit of loose skin there. So yeah, weight fluctuations are a real problem after tummy tuck. Either way, so if you put on weight, again, if you put on weight, you're going to put on weight. The tummy tuck doesn't say, oh, I spent all this money on my tummy tuck and my abdomen is going to be great. You're going to put on weight. And, the worst thing you can do is putting on and losing weight because that will stretch that skin again and cause a recurrence of the problem. But certainly if you're not happy with your weight at the moment and you're thinking you might lose weight after the tummy tuck, my advice is very much that you should try and do that before the tummy tuck because you're going to get a better result. You're going to have less risks because your complication rate is higher with a higher weight, but also you're going to get a better result because we're going to get a maximum amount of spare skin out. And a lot of people will say what a lot of people say. So yeah, so you get a max amount of skin out. So yeah, if you do it at the time, you'll get more skin out. That's right. I know what I was going to say. So a lot of sometimes, especially massive weight loss people, they lose weight and they have such a huge area of redundant skin. They feel really uncomfortable with the skin hanging off them, and they put on weight to kind of take up the slack a bit, which you can understand. But if you're going to have surgery, you kind of want to get to a maximal loose skin situation. So you might find it uncomfortable having all that loose skin, and you might be more comfortable having a bit more weight, which is fine if that's your life. But if you're going to have surgery, you're much better off maximally losing weight, making it kind of look as bad as it can, really, so as much loose skin as possible, because then we'll get rid of all that loose skin, make it tight, and then you can kind of move on from there, rather than thinking, oh, I'm going to lose weight once I've had the surgery. So that is that. Therese in the life jacket. How easy to remove a lipoma from forehead? Would you need follow-up after? Well, Therese, I don't want to make out as if this surgery is easy, all right? I don't want to make that out because otherwise everyone will do it, all right? But usually a lipoma from the forehead is a relatively simple, I would say, procedure. The problem with lipomas is they can be at any depth. So certain areas you can worry about lipomas being quite deep. Now on the forehead, there's not that much between the skin and the skull. So even if it's kind of just on top of the skull, it's not that far away. So you can get rid of a lipoma. So like when we talk about scans and stuff like that, a lipoma on the forehead, as long as it's not like there, sometimes lumps there, we worry about some lumps, they could be something else other than a lipoma, but certainly you wouldn't worry about the depth of the lipoma on a forehead because it's not going to be that deep. So in that respect, they are easier to remove than maybe a lipoma on the abdomen or on the back, which could be deep to muscles and what have you. The thing about the lipoma on a forehead, a couple of things we'd have to be aware of is it's going to leave you a scar. Sometimes you have laughter lines on your forehead, or people do. So if you've got some laughter lines on your forehead, great, we can make it look like one of those laughter lines. If you haven't, we'll put it in a place where there will be a laughter line in the future. But that's one thing, you're trading your lump in for a scar. But they usually fade really well, to be honest with you, when we do put it in the line. And the other thing to be aware of is there's a couple of nerves coming up here. They're called supraorbital and supratrochlear nerves. They come up here and they supply the scalp. sensation of the scalp. They don't supply any movement. So if it's in that kind of area, if it's between the sort of medial part of the eyebrow going back, if it's in that part of the forehead, there's a risk those nerves could be damaged, and there's a risk that the sensation of your scalp might be altered, which is a bit annoying. It's not a massive deal, but it's a bit annoying when you comb your hair. It feels a bit weird. So that is a potential if it's kind of in kind of that area. But that's something we kind of talked to you about. But yeah, in terms of the doing it, it's not particularly difficult. We do a see and treat thing, Therese, so you can send us a photo so we can get an idea what would be involved. You come and have it done, and then you wouldn't necessarily need to be seen afterwards. We do like to follow people up. We always send them off for histology, and we want to make sure the scar's okay. But we can do that with phone calls, emails, video calls, stuff like that. So you wouldn't necessarily have to come back to the clinic for a follow-up unless there was a problem. We could do the follow-ups kind of remotely in terms of the phone calls and videos and stuff like that. So because it's just making sure. Actually, sorry, having said that, you would need the stitches removed. Sorry, which would be a week later. So if you do live far away and you're not able to come back, then you might be able to get your GP to do it. Obviously, we'd happily do it, but that would be the only follow-up. You need stitches removed, because on the forehead, personally, I would prefer to use non-dissolvable sutures, because that's going to give you a better scar than dissolvable sutures. Obviously, dissolvable sutures wouldn't have to be removed, but it does not give quite as nice a scar, and I prefer to use non-dissolvable sutures, which do need to be removed, and we normally remove them a week later. So that would be something you would need to ideally have followed up with us. But if you have if you're unable to, then sometimes we can you can ask your GP to do that if you need. If not, Lynn, thank you, Lynn. Thank you for the input. It's on my husband's forehead. He's also in the live chat next to me. Oh, there you go. Yeah, look at that. Well, thanks. Nice to meet you both. And yes. Oh, well, if it's on your husband's forehead, who cares? Don't care about the scar then. It's not your forehead. No. Well, anyway, the same thing applies. Therese, about the the kind of line in the crease and what have you. So yeah. Thank you, Therese. So. Is it possible to breastfeed after having a breast lift with implants? Again, another one I'm going to get berated for probably, because I'm going to say maybe. What can I do? The answer to these questions often isn't straightforward. The reason that breastfeeding is potentially in jeopardy when you have a breast lift, and it's the breast lift part of it that's doing it, not the breast implants. So if you're just having breast implants on their own, then yes, you can breastfeed, assuming you can breastfeed already. Having implants is not going to alter your ability to be able to breastfeed. Some people can't breastfeed, so you might not be able to breastfeed, but it won't be the implants that's doing that. So implants will not affect your ability to breastfeed, because they kind of go behind the breast. But it's the breast lift aspect of it. So a breast lift, or worse, a breast reduction, both those operations involve moving the nipple. So we have to kind of move the nipple to a higher position. The nipple sitting too low, that's basically the problem with a breast that requires a breast lift. So the nipple's sitting a bit too low, so you can lift the nipple, but that means you kind of have to isolate the nipple. So you're isolating the blood supply, you're isolating the nerve supply, and you're isolating the milk ducts. When you're doing that part of the surgery, you can't see the blood supply or the nerve supply or the milk ducts in the piece of tissue that's going to the nipple. So you don't know if there's certainly enough nerve supply and milk ducts. You can get an idea if there's enough blood supply, because you can see the nipple's looking pink, that's fine. If the nipple's looking sort of blue, then you're thinking, oh crikey, I've taken away too much tissue and there's not being a drainage, it's getting a bit engorged. So but you can't really tell by looking if there's blood, if there's nerve supply or milk ducts in that piece of tissue that you're isolating the nipple on. So you have to kind of hope. Now in breast reduction, there's more of a dissection is done around that nipple in order to remove all the tissue. So in a breast reduction, some breast tissue is removed. In a breast lift, no breast tissue is removed. You only remove skin. So in a breast lift, there is less isolation of the nipple. So there is more likelihood that those ducts will be intact going to the nipple. So there is more likelihood of you'll be able to breastfeed following a breast lift than there would be after breast reduction. Having said that, you still have to isolate the nipple to a certain degree, and it kind of depends on the droop. We look at the nipple to sternal notch distance, so the distance from your nipple to your sternal notch here, and we look at how far we're going to have to move it. So the further you're going to have to move it, the more you're going to have to sort of isolate that nipple to release it and bring it up, and the more risk of problems with the blood supply, the nerve supply, and the milk ducts. So that, you know, if often with people with breast lift and implants, often you're not moving the nipple much. Often it's just a small transposition you need, and so there's less likely to have problems with breastfeeding. But you know, you can never be 100%. So the main thing that ring, I'm not going to say alarm bells, but rings sort of like makes me kind of think when someone asks that question is, I'm thinking, well, hold on a minute, are you telling me you're thinking of having children? Because if you're thinking of having children, I wouldn't have a breast lift with implants, because a breast lift with implants is quite an expensive operation, and a bit like what Lynn was saying earlier about, oh, what if I lose weight after a tummy tuck? I'm not going to say you undo the work, but you know, you can have loose skin again. Same with a breast lift with implants. You have a breast lift with implants, fantastic, happy days. And then you have a child. Well, that's the reason people need breast lift with implants, because children can mess things up. Your milk breasts get engorged, they get bigger, and then when you finish breastfeeding, they often get smaller. Sometimes they stay big, sometimes they get smaller. They can change, is the point. They can change after having children. So ideally, you wouldn't have any kind of breast reshaping surgery until you finished your family, ideally. Now, you might say, I'm not going to finish my family for 10 years or something like that, so I want to get it done now. Fine, as long as you're aware that if you did have children, you might have, your breasts might change shape and you might not be as happy with them as you were. Plus, you might not be able to breastfeed. So ideally, you would finish your family before having this sort of surgery. But it's, you know, if you didn't want to, that's fine. But you'd have to, you know, usually we have a consent form, and on the consent form, inability to breastfeed, or at least in the, you know, we tell you that there is a risk that you may not be able to breastfeed. Although, as I say, if the transposition is small, you might be fine, but we couldn't give you 100% on that. The only way to get 100% is to have a child and see. Because, as I say, some people can't breastfeed, and you know, even without any surgery. So, yeah. Therese, Lol, thanks. We'll be in touch. Good. Look forward to hearing from you, Therese. So, all I can say is thank God for Lynn and Therese. Thank you. Oh, thank God for Lynn, Therese, and Lorena for a bit of audience participation. Thank you, much appreciated. As I say, you, the fans out there, are the real heroes of this. So thank you all for being there. And I'm going to go now. So I will. Oh, I hope you're all right, Lorena. By the way, get well soon. Thoughts and well, maybe many thoughts, really thoughts are with you, and hope everything's okay. And I will, yeah, check out basically, and I'll almost certainly be here next week for more scintillating conversation similar to this. So see you then. Have a good evening. Oh, Jackie, Jackie's here. Jackie, you've defected. Jackie, I'm sorry the Instagram's not working. I've just tried it a minute ago. It didn't work. But you know what? I know my Instagram people are crying out for me. You know, they are. I think the Instagram people are feeling it, to be honest with you, Jackie. They really are. And I can only say that, you know, the IT teams are working tirelessly to try and get Instagram to work. Lynn, what you got? You don't have surgery in London, do you? No, I don't, Lynn. I used to do a clinic in London. I never did surgery in London because well, because you've got to be close to home when you do surgery, and so I didn't really want to stay there and things like that. Although I could, because my brother's in London. But anyway, I didn't want to. And now not. But you know what, Lynn? No, I'm going to say no, especially tummy tuck. It's a no, because you're talking about tummy tucks, aren't you? No. No, simple answer. That's it. I'm not beating around the bush. No, Lynn. We don't have surgery in London. Do you know what, Lynn? And again, you're going to say I'm just saying this. I went to Harley Street, got a clinic in Harley Street, and you kind of think Harley Street's brilliant and all that sort of stuff, and you know, certainly got the name, but it's not as, you know, I think my clinic in Edgbaston's nicer. We're certainly more peaceful. We've got parking. We've got more space. We've got loads of space. We've got space we don't need. We've got got like a basement. We've got a top floor we don't use. And it's a bit pokey. Parking's a nightmare. If you've got a chauffeur-driven car, fair enough, because they can just drop you off and then God knows what the chauffeur does. But, you know, if you haven't got a chauffeur-driven car, it's an absolute nightmare. And can you imagine having surgery in Princess Grace or one of the London hospitals? It's just a nightmare, I think. But that's me, isn't it? I'm not. But anyway, the answer is no. I'm not trying. But yeah, if you're in London, there's lots of good people in London, Lynn. But no, I don't do surgery in London. You know what, Lynn? I don't do surgery in Birmingham either. I've given up the tummy tucks and stuff like that in Birmingham. So, but yeah, loads of good people in London. Yeah. Clinic, yeah. No, I don't have the clinic anymore. I used to have the clinic in 152 Harley Street, and there was a guy there called not Paul Harris, Paul Tully, and well, I went there for a bit and did clinics down there, and then I thought, oh, this is a bit too much, and I know Paul, plastic surgeons, quite small world. So Paul regularly did clinics there. So I said, oh, Paul, why don't you see the patients in the London patients? And he said, yeah, great, fine. And then we had the CQ. I don't know how much you want to know, Lynn. But anyway, we had the CQC come and visit us in Birmingham. And they said, oh, what about your clinic in London? Asking us all the sort of processes and things. And I said, well, I don't know. That's the person who owns the clinic in London. It's another plastic surgeon who owns a clinic in London. I said, well, that's for them. I don't know whether they've got, you know, safeguarding and all these things. And it was a bit like, well, you know, it's kind of your responsibility and things. I thought, oh, crikey. So that was that put the kibosh on that, Lynn, I'll be honest with you. So I said, sorry, Paul, it's not worth the grief that we have to sort of have based on two. It's like anything, you know, if you have a big scale, if you've got 20 clinics, it's probably easy. But if you've got one clinic, going to two clinics is like double the work. But going from 20 clinics to 21 clinics is probably not a big deal because you've got all the processes, you've got all the things. But, you know, we've got everything for the one clinic, but going to another one, it's like, but yeah, so that's the London story, Lynn. Where are you based? Edgbaston, Lynn. Edgbaston in Birmingham, near the. Do you know Birmingham? I'm guessing if you're in London, you don't know Birmingham. Anyway, in Birmingham, near sort of quite central, 5 ways roundabout. Anyway, we're in Birmingham. So yeah, that's a good flurry there, Lynn. All the comments good for the what's it, you know, sort of reach, I think. Yeah, thanks, Lynn. Thanks for participating. Thank you all. And without further ado, I better go and dinner's probably burnt, so I better go and rescue it. And I will see you in the new week. Yeah, next week. So yeah, looking forward to it already. See you then. Thanks, Lynn, Jackie, Lorena, Therese. Thank you all. And all my other fans out there. Thank you all.